The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Welcome to LymphCast, the show that brings together doctors, other health professionals, and special guests to discuss lymphedema, venous disease, and other associated disorders, and what can be done if this is affecting your life. Now it's time to sit back, relax, as it's time to learn all about lymphedema, venous disease, and associated disorders on our show, LymphCast. Well, greetings and welcome to our LymphCast show, episode 19. Glad you're with us, either by video, by audio, by both. And we have an exciting show planned for you today. Let's first meet the panel. From New Jersey, the creator of this show, also the founder, owner of VitaSupport MD. They make Vein Formula 1000, Lymphatic Formula 1000. From New Jersey, physician, surgeon, Dr. John A. Chuback. Greetings, Dr. Chuback. How are you, sir?
Hello, Paul. Doing great. Looking forward to a really fabulous show today. Thank you.
All right, very good. And from New York, RVT, a brand new member of our panel. You'll get to know her throughout the shows. Jacqueline Sasick. Greetings, Jacqueline. How are you?
Hi, Paul. Very well, thank you. So happy to be here. Thank you.
All right, glad you're here. From the state of Arizona, Dr. Monika Gloviczki. Hello, Dr. Gloviczki. How are you tonight?
Hello, everybody. Thank you. And I'm excited to have our new guest, and happy to be with everybody here.
All right, and from California, Dr. Emily Iker. Greetings, Dr. Iker. How are you?
Hi, everybody. Thank you. Thank you for asking. And excited to hear Dr. Bell tell us about his expertise today on this 19th LymphCast show.
All right, very good. And from the state of Minnesota, the gentleman who will then bring in our special guest tonight, Dr. Mark Melin. Greetings, Dr. Melin. How are you, sir?
Always good to see you, Paul. And, thanks again for hosting today. And John, I'm just going to give you another shout out and thank you for creating this show. And it's phenomenal that this is one of the highlights in lymphedema education in the United States. And with that, I want to bring in Dr. Desmond Bell. So Des, a lot of today is going to talk about wound care. And one of the things that we know, and we've talked about many times among this group, is lymphatic functionality in wounds is so important. And it's very underappreciated, very undereducated, very under-researched. And so I think out of today's conversation, we're looking to talk about your background in wound care, Des, and then also get into SALSAL, or saving limbs, saving lives, which really is your heart and passion, and you've had such a huge impact on a nationwide scale for amputation prevention. So with that, I'd like to have the honor and privilege of introducing Dr. Desmond Bell. And Des, why don't you start off with a little bit of your background so our listenership understands where your roots are.
I'm happy to, Mark, and thank you all for having me. And Dr. Iker, I'm glad I made the top 20 at least of episodes. So this is great. No, thank you all. And listen, I appreciate so much all of what you do. Mark alluded to my career as a wound specialist, and I followed my passion in my career. My background, I began my training in Philadelphia, first at the VA Medical Center there, where found that there was such a need for not only wound care, but we had such a high number of amputees. And in my travels around the country, you tend to see this was not just limited to Philadelphia. So over the course of my career, like I said, saw this real need. And I established and followed my passion, established my own freestanding wound care center in Jacksonville, Florida. And I practiced there for about 25 years. With that, some other doors open and some other things became apparent to me. And that was that, we talk about wounds, we talk about amputation, among other things. And you go to conferences, you go to meetings, you understand the pathology, you understand treatments that need to be done, but yet so many people are not getting the message. And they certainly don't understand the importance of trying to heal wounds, preventing amputation, but even how lymphedema ties into all this too. So, I will say in my career early on operating my wound center in Jacksonville, I would have the good fortune of working with several outstanding lymphedema therapists, and learned a lot from them, probably taught them a few things as well, but working in conjunction with them, working as a team, even though we were not in the same practice, knowing who to call and how to address in my opinion, some of the most difficult wounds to treat because of the underlying chronic lymphedema was really an important part of my career.
Wade Farrell wrote that really great paper back in 2010 called Phlebo lymphedema and under-recognized pathology within wound clinics. And certainly in my practice, that was a wake-up call, and I read it about 5 years too late. So as you look back at your career and you say you were working with certified lymphedema therapists, how does that impact outcomes? And what was your kind of tipping point where you realized the critical nature of treating lymphedema? Because the conundrum we're in the United States is most people don't want to touch a wound until the lymphedema is treated, and we realize you got to treat the lymphedema to get the wound closed.
Mark, that you kind of teed it up for me, because one of the things that I would say that became apparent, at least when in Jacksonville, and this is not to slam the medical community in Jacksonville by any means, but where we were 25 years ago, let's say, I would get referrals or consults for so-called venous leg ulcers, and the venous component was not the issue. You'd find any number of things, but it was almost automatically a wound that was on the leg was classified venous leg ulcer. So as I would have patients coming with, obvious chronic lymphedema, it made me realize that there's this lack of understanding of the condition, and not only that, but then how people are treated, and having the resources to get these patients to the right providers who can do, whether it would be manual drainage or even knowing how to do proper wrapping techniques, just trying to make them understand that, you just don't simply put a bandage on it, or you just don't wait, like you said, to treat before, because otherwise things are going to get worse. As you know, we always say time is tissue, and you have to be aggressive in treating wounds. You've got to understand the underlying pathology, because as I always say, the human body it's an engineering marvel. And when people have chronic wounds, it's a symptom of other underlying conditions. You've got to be a good medical detective. It's not necessarily one underlying condition that's causing the open wounds or the inability to heal, but you've got to be able to understand how, the systems all work and how to reverse those trends. So.
And you brought up that really critical point about atypical versus typical venous leg ulcers. And in the United States, we're running into an epidemic of 3 parts: elevated BMIs, or body mass index. So we've got a population that's increasing in weight. We have a population that's increasing in something called metabolic syndrome. So high blood pressure, high cholesterol, again, associated with the weight. And that may or may not be associated with the third part of increasing adult onset diabetes. And all of those things complicate everything that you're talking about, Des, in terms of preventing amputations and getting wounds to heal.
Absolutely. I will, Mark, you just touched on something I think that I've seen over the arc of my career too, is that, earlier in my career, I jokingly called them, I would see a lot of some boo-boos, nothing really truly limb threatening, but as my career advanced, I saw not only more severity in the wounds that I was treating, but also started seeing younger and younger patients coming in. And that was probably, to me, the most disturbing thing. And this kind of was borne out. I remember my first year in training back in Philly, we had a diabetic education class, and we teach diabetics newly diagnosed things that they do to be proactive and that sort of thing. And I remember one of my co-residents saying to one of the vets, we're really close to a cure. This is a really good time to have been diagnosed with diabetes. So we had 16 million people with diabetes, and that was 1996. And so here we are in 2023, we're well over 34 million now. There's no end in sight. We've got probably about 88 million who are pre-diabetic. And so this all, what you just touched on, Mark, it's we're going to see more severity. You're going to see more lymphedema issues. You're going to see more renal disease. You're going to see obviously more vascular disease and all the bad things that go with this. So, as you know, in the real simple sense, it's so much easier to prevent than it is to treat. But, the genie's out of the bottle. We have so much work to do, and we have I honestly don't think we have enough true providers who can address some of these issues.
There's, of course, that I'm a Northern New Jersey guy too, so we have that in common. And going back to my training in general surgery, I spent a few months at Crozier-Chester Medical Center just outside of Philly at the Wound Care Center. Had the great privilege of spending a significant amount of time there with a great physician and surgeon, Dr. Linwood Haith, who was a burn specialist. And Linwood is somebody we should have on the show sometime. Amazing person, and saw some of these challenging wounds that you're talking about. And then, of course, more as my surgical residency and so forth proceeded. But one of the things I want to bring up that you mentioned, and we go over this again and again, and I think I want to take it from a patient-centric view, because lots of times those of us on this program, we get kind of we go down our doctor rabbit holes, and we get into some technical things that some of our listeners who may be patients may not understand. And we're here to educate and explain a lot of those things to them. But here's a really fundamental piece that I know that we all have in common, that we share. When you use this expression, you have to be a good medical detective. I couldn't agree with you more. And to be a good medical detective, what you're saying is you have to be a good doctor. And in order to be a good doctor, I have my notes here. I'm always taking lots and lots of notes with our guests. I think the bottom line is you have to care. You have to really care about people. You have to care about patients. Jackie, who's new to the program here, but Jackie and I have known each other almost 15 years. She was the director of my vascular lab for many, many years. She's here on the program too, because she's a person who cares about people in general, not just patients in the clinic. But what we're finding, and I'd like to give advice to our listeners. If you find that you have a doctor who doesn't seem to care, or a healthcare provider, a therapist, whomever it is, I urge you, I implore you to look for somebody else. Get a second opinion, a third, a fifth. Keep looking, because it's getting harder and harder to find someone who really cares. And I don't think it's because people start out not caring. I think we all get drawn to a career in medicine because we do care, and we want to be, and nothing is more appropriate than the wound care subject than healers. We want to be healers. We want to make people well. We want to heal them. But with the way healthcare is changing and medicine is changing, where everything is being driven by the almighty dollar, we're getting more and more of corporate, we're getting more of big money in medicine, we're getting more of venture capital and private equity and so on and so forth. And physicians are being driven to do tremendous volume and achieve numbers and so on and so forth. It becomes almost impossible to have the time to show compassion and to show interest. Joe Magnet, who I'm sure Jackie knows and some of you may know, who's a great educator in ultrasonography. One of the great things he taught me when I was first getting into ultrasonography 16, 17 years ago, to have an actual probe in my hand, is you have to be curious. You have to be, interested in what is going on here, what's wrong with the patient. And so, Des, when you talk about being a good medical detective, I think it's so, so good. And I think our patients have to understand you have a gut instinct, for the listeners out there who are patients, who are sufferers. If you don't feel the person taking care of you cares about you, is interested in you, is curious about finding out what's really your underlying problem, as opposed to writing a quick prescription, throwing on a quick bandage, or doing a quick debridement and flying out the door, you'll know that and you'll feel that, and trust your instincts, because what Dr. Bell is sharing here is essential. The good doctors and the good nurses and the good technicians and technologists and therapists, everyone in the healthcare team, you'll know when they care and you'll know when they don't. And if you're in a place where they don't care, get out of there and keep looking, because you need to get in the hands of people like Dr. Bell and so forth. So if you'd like to feedback on that, Dr. Bell, I'd love to hear your thoughts.
John, thank you for the kind words, but you're spot on in many aspects of not only the issues, but I was fortunate in my career, because I found, or I should say, wound care found me. I didn't find it; it found me. But the beautiful thing about wound care, and there's this irony in that we're dealing with some of the sickest people who have, in many cases, they've been not given too many other options, and they're forlorn. They're living with these wounds that their whole life is miserable. There's depression. And it's certainly not a sexy area of medicine. It's dirty, it's smelly, there's a lot of drainage, et cetera, et cetera. But I found it every day going to my office or the hospital. It was so gratifying. And you could, one of the beautiful things about wound care is not only can you see your results pretty quickly if you are making a difference, but you're able to spend time with your patients. Unlike some of the scenarios that you were just describing, where so many of our colleagues are getting pressured to see, pure volume and RVUs and all these type of things. Having my own center, which really grew out of my own little practice, I was able to do things that I felt had to be done the right way, and it just grew. And that was the funniest part of it, is by following my heart in doing this, I grew a very successful practice as a result. Never had to advertise anything. It all comes.
It's amazing how that will happen if you, as a physician, take good care of people. You'll get busy. People will spread the word.
It's so true. I would always joke. I'd say, Jacksonville, Florida, it's a big city, but it's a small town. And I said it's not 6 degrees of separation; it's 2 degrees of separation. Mm-hmm. And rule of 5 is really held true. I mean, if you did something good for somebody, they would tell 5 people. But if you did something bad to somebody in that town, they're going to tell 5 people in 5 times as fast as if you had done something good. So, I always looked at myself as like a field goal kicker. You can't pat yourself on the back too much if you have a good result, or, get somebody all healed up. We're the middlemen anyway. The body's designed to heal itself. But you can't sit back. There's no time for that. You just got to keep pushing ahead, because there's more people that need your service. So, it's just a wonderful part of medicine to have been in for all those years. I got more from my patients. Seriously, it sounds cliched, but I really did. It was at times it could be like a dysfunctional family, but I keep in touch with some of my old patients to this day. They reach out to me, and it's really kind of mind-blowing in a sense.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
I was just thinking, like about what you said, which is very true in my opinion. That these patients are particularly vulnerable and have this aspect, like you said, that they are dirty. You have anybody with the heart attack, with the, I don't know, some other disease, and everybody is like, compassionate. Oh, poor you, you had a heart attack, and so and so and so. And those patients are for years with the open wounds, sometimes years, truly, and not that much interest from the family because it's chronic, it's dirty. So that there's that psychological aspect which is extremely important for them, and certainly the practitioner, whoever it is, a physician or a nurse who is treating them humanly and trying to help, is so such a key role to play, maybe also in social dimension.
Absolutely, absolutely. You are absolutely correct. Our patients with chronic wounds tend to become, like we sort of touch on this, but they do become, many of them, shut-ins. They stop associating with their family and their friends. They're embarrassed. Their body image is just totally disrupted. And one of the things that a lot of people don't understand too, especially when you're getting into things like diabetic wounds, who are a lot of my patients, those wounds do not heal in a timely fashion. There are very high mortality rates associated with the non-healing aspect. And it's there's been a lot of published information on this, comparing it to people who have chronic disease like cancers. They say, like, as an example, a diabetic foot ulcer may have somewhere close to a 5-year mortality rate of about 50%. But it's all the other bad things that go on with it too. So, whether it's a wound that's being exacerbated by chronic lymphedema, whether it's, some other underlying cause, they all share the same type of physical and emotional link that doesn't matter what the etiology is. The fact is they've got this open wound that should not be there, and how it impacts them.
So tell me about this saving limb saving lives.
Yes.
Because, of course, I believe that's such a beautiful motto, and that is something that we should have in mind for wounds, and not only for like the critical arterial complication situation.
Well, again, it kind of had humble beginnings. So our foundation started this foundation. It really kind of grew out of my practice once again. And it wasn't called the Save a Leg, Save a Life Foundation at the time. But witnessing several things in my own clinical practice, watching patients struggle just the way cancer patients do. They're chronically, constant trips to the doctor's offices or hospital, in and out, seeing what it did to patients themselves, but also to their support system, their family members, their friends. And then just knowing that too, we had technologies that we have available that are being underutilized. We identified such a lack of fundamental understanding on how to treat chronic wounds, whether it be from the vascular side, whether it be through some basic fundamentals, if it was a diabetic foot ulcer, whether it's venous leg, whether it's chronic lymphedema. So we said, this is not acceptable. We talk about it, we talk about needing to educate, but I kind of looked at an open wound on somebody's body. Okay, if a woman were to have a lump on the breast, okay, the wheels are in motion, referrals are made, go to oncology and treatment. Yet when you've got an open wound on the leg or diabetic foot ulcer, it's crazy, but where vascular disease is involved, it's been estimated that almost half of the amputations done in our country are done without any type of vascular evaluation prior. So we've got so many issues that have come to a head, but nobody talks about it, or nobody's really done anything. So
Des, I hate to interrupt. Can you say that again, what you just said? That's startling what you just said.
yeah, John, the first time I heard it, I almost fell off my chair. I was at a meeting.
The first time I'm hearing that, personally.
Yeah,
I think that's insane.
The first physician who presented was David Ali out of Lafayette, Louisiana, and then this was validated too by a group called the Sage Group that looks at, they're sort of Mary's background was she was a Wall Street analyst, but they look at peripheral arterial disease, and yeah, they found that in our country, approximately half of the non-traumatic lower extremity amputations that are performed are done without any type of vascular testing beforehand. So amputation becomes subjective, and because patients don't know what questions to ask, or maybe don't understand the disease state, they just accept it. But
that's just an incredible statistic. I would think it would be higher than that in a third world country. I mean,
well, that's what, and I've said the same thing. It's like, this is third world medicine we're practicing in the U.S., but where's the outcry over this? And what other area of medicine is it acceptable to remove somebody, a part of their body, even a wisdom tooth, for crying out loud? You got to get an X-ray. It's so simply just saying, okay, I think that leg needs to come off now. It's mind blowing. So just felt that we need to do better, and we have to get the general population engaged in this and make them they have to be their own advocates. But before they can do that, we have to educate them. We've got to do any number of activities to get this messaging out where it needs to be.
Well, this is hopefully a big part of that, and that's why it's so exciting to have you as a guest. Jackie can recall there was a time when I was called. I mean, you're really raising an interesting point. I was called to the hospital to see a patient in the emergency room, and the consultation was for amputation. I mean, imagine that. The emergency room doctor puts in a consultation, call vascular, for an amputation, not for an evaluation, an amputation.
Mm-hmm. And
it was a young man, 36 years old, with long-standing chronic venous ulcer, circumferential, what we used to refer to as an apple core lesion,
yep.
Married with a teenage daughter. His wife hadn't seen his leg in years. He was totally humiliated, embarrassed. It was malodorous and infected. It was a terrible situation. And long story short, we brought him, I treated him in the hospital for a while, and then we started treating him for a long period of time in the office and got him healed. Jackie, you remember who I'm talking about, right? And it was amazing to me that someone would put in a consultation for an amputation. But when I'm listening to you, the horrific part is that there are people who will go and do that. I mean, it's hard to believe that in the United States of America, when you're trained and educated and whatever else, and hopefully, board certified and the whole thing. But again, I would get called, let's say, for example, for greenfield filter insertion. I mean, that's the consultation. Call vascular to put in a greenfield filter. I go to see the patient. There was no indication for a greenfield.
Yeah.
Patient's first DVT had never been anticoagulated, never failed anticoagulation, didn't develop a DVT while on I mean, none of the indicators. And then I have to have an argument with the referring physician, who then begins to threaten you. Well, if this is going to be your attitude in the future, maybe I won't call you. I mean, it's not like ordering.
Yeah.
It's not like ordering a pizza. I mean, you're calling for a specialist. You're calling for some expertise. I just want to pass the torch here momentarily to Jackie, because I know that, so many of these things resonate with her. She has many, many years of vascular technologist experience as a RVT and RPHS, working many years in the hospital before joining my practice, doing arterial and venous of all kinds. Jackie, if you could give a few thoughts and maybe ask Dr. Bell his opinion. I know you have strong opinions about diet. I know you have strong opinions about the American diet direction it's going, obesity, increased BMIs, and also this idea, I mean, that someone could undergo an amputation without any vascular diagnosis or investigation at all?
I have a lot of thoughts, One of my immediately as Dr. Bell was giving out numbers as to the increase of diabetes and such, and to Melin too was talking about BMI and so forth. I'm just curious if all of you, if you feel that this is part of the mental health crisis that's going on right now. Are these just symptoms of poor mental health? Is really a big question that I have.
Jack, you just raised something that's important too. Here's another little thing about wounds too, especially when you're dealing with diabetics. Unlike, let's say, breast cancer, which, for lack of better terms, people see this, it's a high profile type condition. One of my colleagues said, oh, what we do is not sexy. That's sexy. But there's a certain amount of a mindset too, that people look at people with wounds and they say, they kind of blame the victim. And they put it on that, oh, they caused their condition because they were diabetic, because they didn't take care of themselves and all that. These are the kind of fallacies that are out there. And for nothing else, what should drive everybody is, if that person across from you in the treatment chair, pretend it's your mom or your dad or your grandmother or somebody that you loved. And that's how you have to proceed. You don't just sweep them under the rug or just, don't offer them the best possible care, especially if you know that there are resources available. If you don't want to do it, if you don't want to do the work, that's fine, but get them to somebody who will do it, or who's engaged and wants to, enjoys this kind of work. So it's just, we can't just allow this we can't be passive in this.
And one of the things in mental health, because tying in macro, micronutrients, so many of the patients that we see coming through the wound clinic have a low level, if not a obvious state of depression. Many documents show at least 30, if not 40% of our patients have some degree of depression for all the reasons we talked about. Well, some of the really low-hanging fruit to talk about are folic acid, which should be standard of care for management of states of depression that go along with an SSI. And we could talk about B12, B6, all the things that make endothelial cells work. We should be talking about diosmin, micronized purified flavonoid fractions, with the plethora of data and the pleiotropic effects that are there. We've seen it in diabetes. We've seen it with venous hypertension, with lymphatic function. But as I sit here in clinic and go through all these things with patients, the first thing the patient looks at me and says is, that's all great. Who's going to pay for that? And so it's another one of these double-edged swords where we have the tools, we have the data. Applicability can stop because of the patient's ability to afford what we know is really good for them. And that holistic care, Des and Monika practices holistic care, John practices, Emily practices holistic regenerative care. That's what we need to get to, but we need to be able to support the patient's pocketbook.
Absolutely, it's always a consideration, Mark. Absolutely, the nutritional thing. Jacqueline, you just jogged my a thought too. I kind of would pay attention. Obviously, a lot of our patients are very large. Are diabetics, but across the board, many of my patients, I had very few who were thin or slight in their build. I would look at their nutritional indices, and I can't remember one who was not malnourished. all the years of practice, every time if they'd be hospitalized or in the wound center, you just some basic things, just their protein levels. Not to mention, you get into some of the others that you were describing, Mark. So I guess society has changed so much. And when we're all growing up, you're home at a certain time, the family sits around the dinner table, and nothing was fast food. And now we're just this manic pace all the time. And it's just, it can't be good for anybody.
Manic is a great word for it. It's become actually quite insane.
Really
quite insane, for lack of a better term. And I mean it really quite literally. Jackie, why don't you share some thoughts with our listeners again? What do you think are some really fundamental things? Let's say we talk about patients being overfed and undernourished. We talk about people who are obese, who have elevated BMIs, but are malnourished. Why do you think that's happening? And what do you think are some common sense things that a listener might be able to implement in their life in terms of nutrition and exercise as a starting place?
Walking, water, the basics. Just like I would say, I have told patients in the past, even if you break up your exercise routine into 10 minutes per day, 3 times a day, you'll get 30 minutes in. And that just walking alone is one of the best things you can do for your mental health and your, again, Dr. Chuback, that's my passion, is bridging the gap between mental health and physical health. I feel that you can't have physical healing without emotional healing, right? And I think that you also need to reach out for help. That's why I was asking if if the diabetes and the BMI are going up, because of right now we are in a mental health crisis, right? And are people just overeating? Are we not taking care of ourselves because of depression? Are these patients developing these conditions and things and so forth and so on because of that? I'm just curious if that's why the numbers are going up. But yeah, if I had to give any advice, it would be to walk, drink a lot of water, and to find somebody to talk to, whether it be, there are so many resources right now out there for, like Dr. Melin was just saying, that people are suffering with depression that come into his wound center, and that needs to be addressed.
I think that's amazing advice. Walking and water, the 2 W's, because as we all know, and we'll share again with our audience, too many times people are confusing dehydration and thirst for hunger. And it's because we're living in a chronically dehydrated society. If you watch any of the big stars, the athletes, the movie actors, the actresses, they will tell you they're fanatical about hydration. And Tom Brady recently said, "I'm the most hydrated person on earth." And you think about how serious he is about his fitness and his conditioning. So walking in water. And again, when we talk about Dr. Bell's Sal situation, as a surgical resident, general surgical resident, cardiovascular surgical resident, the fundamental exercise regime for limb salvage in claudicators, let's say, was walking. The 30-minute walking regimen: walk till you can't walk, stand and rest, and walk again, stand and rest, walk again, stand and rest. So this is amazing advice. And another person we need to have on the show sometime is Barry Franklin, PhD from Detroit, who runs the big cardiac rehab program up there. His book on walking, I'll give it a plug. It's called Two Feet, One Heart, or One Heart, 2 Feet. I think you can still find it on Amazon. Very, very simple read, written for lay people, but lots of data and research there. I think that's phenomenal advice. Dr. Bell, your idea on walking in water?
I couldn't agree more. And I would offer my patients the same advice over the years. Like, Dr. Bell, what can I do? What kind of exercise? Like, look, let's start with walking. Okay, just get out and walk. And just trying to let them understand too, the hydration part is so important too. So, always be educating. There's always teaching moments in every patient encounter. And if you I love what you just said, Jack, too, about breaking it up into doable segments. Okay, yeah, 30 minutes might seem overwhelming, but start out with a few minutes. Just get moving. Just walking. That's so important. It's so important, especially our patients, again, with multiple comorbidities. So many of them have coronary disease, peripheral arterial disease, as well as their venous or lymphedema, neuropathy. It goes on and on. So you can't just sit back. You have to get moving. It's the best thing.
One of the fascinating, I'm going to bring Dr. Iker and I'm going to bring Emily in here too, because we haven't heard from her yet. And I'm sure she has some amazing thoughts about all this. But one last thing I want to say about this walking subject for patients who are listening, because this program is for you guys. This program is for our colleagues to learn more about the subject, but it's really primarily, I created this program for patients and people who are suffering from these various problems, whether it's lymphedema, lipedema, venous insufficiency, ulceration, diabetes, diabetic wounds. This is for you. So here's one thing I want to share. Dr. Franklin shows great data in his work and his lectures that if you're a fit person walking an hour a day and you decide instead to walk 2 hours a day, the improvement of your health and your longevity, your survival change is almost nothing by adding an additional hour of walking if you're already walking an hour a day. But if you're someone who's really sedentary, if you're somebody who's down and out, you have these problems. And as we talked about, you may be feeling depressed. You may be feeling unhappy. You may be feeling isolated. You may be spending a lot of time in bed or on the couch or in a chair. What Dr. Franklin has shown is that for you, as Dr. Bell and Jackie are pointing out, 5 minutes of walking can have a dramatic effect on your health and your long-term survival. 5 minutes, going from 0 to 5 minutes is much more important than the person going from 1 hour to 2 hours. And I'm not making this up. This is the data. This is what the research shows. So don't think that if you're only capable of doing 2 or 3 minutes without becoming out of breath or having to take a rest or whatever, that you're wasting your time or you're not achieving anything. You are achieving a lot by getting started. It's the people who are just beginning and begin to do a little bit that see the greatest return on that effort. So please don't be discouraged. And the one other thing I want to say about the psychosocial and emotional issue is that it becomes a little bit of the question of which came first, the chicken or the egg. Sometimes there's some depression and so forth that may lead to overeating and a sedentary lifestyle, which then leads to weight gain, which then leads to more feelings of guilt or self-loathing and so forth, self-judgment and all of that. And then it can become a very vicious cycle. And we understand that. And as Jackie said, do whatever you can to reach out to somebody to talk about it, a friend, a family member, a clergyman, a social worker, a psychologist, if you have access, anyone that you can talk to, because in addition to walking in water, I think talking and getting it off your chest and verbalizing is also very, very good medicine. With that, I'm going to hand it over to you, Emily.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
Well, thank you so much. What an exciting talk show. But I do want to point out from time to time, not only I have lymphedema patients and lipedema patients, but combination of both, and lipedema, lymphedema with wounds. And I compliment you, Dr. Bell. If once you help these patients with the wounds, they are so helpful and so grateful for all the work that you do. Yes, because it's not very glamorous to do the bereavement and apply all the dressings and then the bandaging. And bandaging, I have to point out that we just lost a great hero, Dr. Hugo Parch, who is a proponent of the bandaging and wrapping for all these swollen lower extremities and upper extremities. He was a dermatologist from Vienna, and he passed away a few days ago at the age of 83, and I was honored to personally know him. But all these patients with lymphatic disorders and venous insufficiency, and so when you look at them, indeed, they are overweight. And I think you pointed out so important the nutritional aspect, and eliminate, and I teach all the patients, don't ever reach in a supermarket for any processed foods. Try to eat healthy and fresh foods, and you can easily cook that. And there is a very good book from a bunch of us that contributed to it's a nutritional guide for lymphedema and lipedema, and there are a lot of even tips on how to prepare certain foods. But most of my, pretty much all of my patients are now on the lymph formula, which is with the micronized purified fractional aspect of bioflavonoids, as well as for the venous component patients, I keep them on the vein formulas, and the patients have very good results from those. So I would not only combine the good care from the physician and to be a detective, and mainly to undress patients, because a lot of patients are just seeing the doctor and here is a prescription, have an MRI, have this and that. And if needed, as you pointed out, here is an amputation evaluation without any pre-evaluation of is it necessary and can we avoid that also. But combination of a good physician who would be good detective to diagnose properly and then treat the patient properly, and then teach the patient about nutrition, exercise program, and everything else. So put everything into one holistic approach instead of just looking at the arm, looking at the leg, looking at the one component of the body. And you are doing tremendous work with, and too bad you are so far away, because we have so much need for you in our area, where a lot of patients, last patient that I had was combination of overweight, lymphedema, and phlebolymphedema with the wounds, open wounds, and he was ready to give up because nobody was addressing his wounds. Fortunately, and it was a little bit lengthy process, he got better and he lost some weight, and he is so happy. The expression of gratitude in these patients that we help is enormous. So compliments on this fantastic work and great talk that you are enlightening everybody that there is a help and there is a good outcome if we teach the patients how to take care of themselves.
Actually, Mark just sent me the message, and that's really something related to this topic. That our good friend, Professor Parodi, who is a giant in the vascular surgery world, published a study showing that good hydration actually improves the walking distance in patients with the arterial disease. So just to add a little drop to the all the discussion about it, and
that's amazing.
I would add also one another thing: hope. You know, we need to. There's a positive energy that we need to give to everybody, to physician and patients. Very often, it's such a stagnation with this situation that it's like despair, depression, nothing is going well, I'm obese, I cannot move, and if I move, what for? It's all this vicious circle of the lot of elements added and finally killing patients.
Such a powerful thing you just said, Monica, and that hope aspect. You know, a lot of times the patients that would come to my clinic, by the time they were referred to me, they'd already been told that there was nothing else that could be done. And sometimes I'd even lock horns with other colleagues from different disciplines and say, why don't you just get the leg amputated? And, you know, it's like, you want to me, a 20% chance is better than zero, okay, when it comes to this, because when you amputate a leg, you know, you're not solving a problem, you're creating a whole host of new problems for these people. So I think we owe it to them to at least explore. Look, you can't, you know, get everybody healed up. That's, you know, it can't happen. You can't prevent every amputation, but you sure as hell have to try. You've got to do the best for them. Just again, there for the grace of God go I. If that were me in that chair, I would hope somebody would go the extra bit for me. That's all we can do.
I think that's a great comment. But and I think we should point out, and I'm sure, you know, Des and I have never met before, so it's an important discussion. But the other side of the coin is, and we should always look at all sides of the coin, again, for patients listening, just as the immediate amputation is totally inappropriate, the other thing that you sometimes see is the endless, hopeless preservation. Now, because if a patient is suffering with an ischemic limb, a non-healing wound, all revascularization efforts have been made, nutritional, wound care, et cetera, et cetera, et cetera. The other thing you never want to see as a physician is a patient who is suffering unnecessarily, chronically. So there is always, and I'm sure Dr. Bell will agree, there is a time and a place for a good amputation, for a properly performed amputation that will end suffering for a patient. But all other options should be exhausted first. It should be a last option.
Yeah, you've got to investigate. And as you know, it doesn't matter if it's this area of medicine or something, your patients will tell you when they've had enough too. And you have to be keenly aware too. You've got to constantly be checking where they're at emotionally, physically. So you just don't do wound care just for the sake of just get through the week. You know, you should always go in with a plan and what kind of a stepwise approach you may need to get to your objective. Sometimes palliative care is all you can offer, but you also want to make somebody comfortable in that case too. So, you know, it's every day it's different. The challenges, as you know, will always be there.
I want to share an interesting thing about micronutrients and so forth. Mm-hmm. One of the great misconceptions that American physicians have been led to believe is that dietary supplementation is unnecessary in America because everybody in America is well fed and so forth. Jackie and I had a very fascinating experience some years ago where we brought in for about 5 years a medical weight loss program into the practice. And one of the aspects of that weight loss program were that initially the patient had to have a full battery of blood tests, including vitamin levels and so on, and micronutrient levels and so forth. In 5 years in New Jersey, 15 minutes from the George Washington Bridge, we never had a single patient with a normal vitamin D level. Mm-hmm. I was so fascinated by it. I had myself tested, and my vitamin D level was unbelievably low. Right, Jackie? I mean, less than half of normal. And I was shocked. So this idea, the point I want to bring out, this idea that because you're well fed, and I think that I have a fairly good diet, I eat fresh fruits and this, right? I don't have a problem with access to fresh foods and so forth. My vitamin D level was deplorably low. And we know how important vitamin D is. Dr. Melin can talk to us about the importance of vitamin D. And part of it is we're not living in South Florida, of course, where your vitamin D levels are probably higher, but everyone is also convinced that if you get any sun exposure, you're doomed to die from skin cancer. So nobody's getting sun exposure, and you're not getting it in your dietary. So my point is that one of the very simple things that I ask all of my patients with wounds to do is to take a multivitamin and supplementable vitamin D. It's not, we were taught in medical school, oh, you just urinate that all down the drain. It's a waste of money. You're just supporting the dietary supplement industry for no reason. I couldn't agree more. Now, if you want to go get tested and see where your deficiencies are and treat them specifically, that's fine too. But for most of us, I think a good daily multivitamin and some extra vitamin D is helpful. Mark, do you have any thoughts on that?
Well, everything we're talking about in vitamin D actually works on endothelial health. So we can't heal without our 3 trillion endothelial cells working. So that's why we expand from a multivitamin. I think if you're in good health, a multivitamin is good for maintenance, especially if you eat well. We tend to superdose almost everything. So a multivitamin, we specifically target B12, B6, folic acid, vitamin C, vitamin D, zinc, 2 weeks of vitamin A right up front, even if you haven't been on prednisone. And that's our recipe right out of the gate. And then we're putting everybody on diosmin, micronized purified flavonoid fraction as well, because we know the benefits from a venous hypertension standpoint, the lymphatic standpoint, which I'm convinced every one of our wounds has lymphatic dysfunction, whether it's a diabetic foot, whether it's a pressure ulcer, a gravity-dependent position on the coccyx or sacrum, they all have lymphatic dysfunction in those regions. And I just wanted to say one last thing was, we got to stop looking at amputations as an amputation and start looking at them as a reconstruction. And a reconstruction starts with getting your head in the game, helping the patient, give the hope that Monika talked about, get in with a prosthetic, pre-having to get the edema out of the leg. So, because so many of these critical limb ischemia patients have lower extremity lymphatic dysfunction plus the peripheral arterial disease. And too often an amputation is relegated to the most junior person on the surgical team. It's a reconstruction, and I think we have to start taking these amputations pretty seriously. And just like there's critical limb ischemia teams, I think we got to start creating reconstructive limb loss teams that are interdisciplinary with PM&R, with vascular, with wound centers, with cardiologists, with renal, etc., because that's how we're going to get it right the first time. And I'm speaking from a guy who's failed way too many of my patients in the amputation.
Mark, you just made me think of something too. In the emergency department, STEMI comes in, they have protocols, everybody knows what to do. Somebody presents sometimes with a severe P80 or critical limb ischemia, which we call a foot attack. They send them home. So many, people they miss this type of thing. So, you're right. It's a team approach. It doesn't have to be under the same roof either, but I think it's so important within a community to identify people who get it, and you work with them and you develop that network. And over time, other people start to notice too, other professionals, but it's the service you have to provide. They're too complicated.
I think that's so fantastic. Foot attack. My background is cardiac surgery, open heart surgery. I did for 6 years I was in practice. And actually, Mark and Monika and I are going to be presenting a poster at the American Venous Forum. This is kind of a spoiler alert. I'm putting it out there, but I want the world to know this is my concept, so don't steal it from me. You're hearing it here first. We have because I'm a cardiac surgeon and I was working with so many patients with congestive heart failure, CHF, and now I've been doing venous insufficiency for all these years and dealing with patients with venous leg ulcer, I came up with this concept of congestive limb failure. And so CLF, we call it. So when you talk, which is from venous insufficiency, and of course, all of the lymphatic dysfunction and pleural lymphedema that goes along with that and leads to necrosis and tissue loss. So the other side of that, this is such a beautiful combination. We have to write something together sometime soon. So you have CLF, and then you have foot attack, which is your arterial side and ischemia. And then, of course, there are times when you have mixed disease. So you have a patient with CLF and foot attack. So that's the first time I've ever hearing that. And I think it's a terrific moniker because it gets people's attention. You know, that's like when they started calling, you know, rather than stroke, like a brain attack. So you have a foot attack. So that's terrific because it's an attention getter, and hopefully get the attention of our colleagues to treat those patients, not like a chronic condition, but more of something that needs to be addressed immediately. And
yeah, absolutely. Yeah, and that's really what, you know, the term "save a leg, save a life." When I first wrote that down on a napkin years ago, I didn't know what I was going to do with it, and our foundation evolved, and that's what we're going to call our organization. But you know, it's not only about preventing amputation; it's connecting the dots between vascular disease, between heart attack, stroke. You know, all the things that these patients have high risk for. And it's incredible. You know, I worked very closely. In fact, for about 4 years, I was part of a interventional cardiology practice in Jacksonville as well. And you know, you just have to, people just have to understand the link and how important this is, and working in conjunction with each other. These people are too complicated. They're medical time bombs, really. And to try and handle it by yourself, it's just, it's to me, it's really irresponsible. You've got to, again, look at all the underlying issues here.
As we come to the end of our time, I just want to ask one thing, and then we'll pass it around for last questions or comments. Save a leg, save a life. It's a wonderful name. So I have a very fundamental question, and I don't know the answer to this. So this is why these talks are so important. As a surgical resident, cardiac surgeon, and everything else, for all those years, we would hear these dramatic statistics, and you'll remind us of where we are on those statistics now. I think you mentioned it earlier, that if a patient has an amputation for vascular, non-traumatic amputation, there was a significantly reduced 5-year survival rate in those patients. And you can tell us what the latest figures are. Is there any evidence to show that salvaging a limb and getting a limb to heal has any impact on survival?
Not only that, but it's also more cost effective to the healthcare system. So it's like the double whammy. It's actually, yeah. You know, we've been kind of stuck on this 5-year life expectancy when all those bad things start happening, and even the ability to ambulate after amputation drops dramatically. You know, like half the amputees below the knee will ever walk again. Less than 25% above knee will ever walk again.
So how does the data explain that increased survival? Is it because of mobility, decreased PE, et cetera, et cetera? Can share that with us? Yeah,
it's probably a combination of factors. Again, going back to the multiple comorbidities that the patients have. So, you know, I would have, as an example, how many times I'd have a patient in the chair, and I'd call the bat phone. I'd call my interventional cardiology friend and say, listen, here's what's going on. You know, I got this, you know, we've got somebody with, I suspect, significant PAD or CLI going on. Get him in for referral, and you say, call me back, you know, the next day or something. Listen, we evaluated them. We found that there were some other issues that needed to be tuned up too. So, you know, we found some blockages in the cardiac vessels. So we have to address that first. And so getting them tuned up in a sense. So, you know, this is quality of life, and addressing all those other issues too. Probably that's what leads to those, you know, getting past that 5-year, let's say that magic 5-year mark.
Paul, anything from you as our layperson and our great host? We always come up with a great question from your perspective.
A couple of things. You know, first of all, I'm amazed and fascinated as a layperson because I didn't know this, that doctors, physicians spend all this time in medical school and training and do what they do, and they devote their entire practice and their entire life to wound care. I think that's amazing, and I'm great to hear that. I'm not in need of that care right now, but if I ever am, I'm going to know where to go. So I appreciate that on behalf of all of us. Dr. Bell, I'll address this to you. I think I heard a couple of times. The last time I heard it tonight was from you. You used the term, if I pronounce it correctly, palliative care. In
Yes.
simple terms, can you explain what that is?
So palliative care really speaks to the fact that sometimes a wound is not responding to treatment, but it's usually because there may be some underlying issues that, the patient maybe doesn't, their life expectancy may be not long. There could be malignancies within the wound. There could be any number of other reasons. Just let's say patients who unfortunately maybe are in a nursing facility, you just want to provide comfort care. You don't want to do anything outrageous to subject them to more surgeries or anything that might cause additional pain. So that's what we're referring to.
Okay, I appreciate that very much. Dr. Chuback, I'll turn it back to you. Where would you like to go next?
Well, I think we're going to wrap it because we're running out of time, but we could go on for hours with this incredible panel and this incredible guest. The one thing I want to thank Dr. Melin for, again, is introducing me not that long ago, and I've been taking care of patients with wounds for close to 30 years. I am, embarrassed to admit in some ways. We're getting up there, but the idea of he uses this term, the idea of the wounded patient, and I think Jacqueline really pointed that out, that these patients, in many cases, not all, but in many cases, are wounded in more ways than one. They are wounded physically with an open wound, but they can also be wounded emotionally and wounded psychologically. And I think that, as was pointed out by Mark, the holistic approach is essential, and that's why these teams of people are essential. But we have to be so cautious as specialists and subspecialists that that's, oh, what kind of doctor you're? Oh, I'm an eye doctor. I'm an ear, nose, and throat doctor. We have to remember that we're doctors and that we're seeing the whole patient. And it begins with a good history and physical. And physical examination, as Dr. Iker said, means taking your clothes off, letting me examine you, letting me see you, your skin, your body habitus, your posture, anything that you may be hiding from the world, from yourself, from your physicians. And we have to, in so many ways, just in general, get back to basics, because as we came to that conclusion, so many things are moving toward insanity, and we have to go back to sanity and good healthcare. So I'm going to leave it with there, Dr. Bell, some final comments, and then Paul, I think, will take us out.
Well, I want to first of all thank all of you for being so gracious and allowing me to share my little bit from my world with you. Dr. Melin and I are, we're kind of kindred spirits in this. We've got a lot of work to do for sure. And I'll do a selfless plug here for our foundation. If people do want to learn more about it, our website is actually undergoing some renovation right now, but it's still up. But it's the salsal.org. So the Save a Leg, Save a Life Foundation. Some of the things that we do too, because we didn't really get into that, we've done a couple of different projects. One of them is we offer a scholarship to try and help healthcare providers who maybe want to sit for board exams or in wound care. Maybe cost is an obstacle. We have also started something called the White Sock Campaign every September. September is PAD Awareness Month. Most people don't know that. We came up with this idea of putting one white sock up over your pants leg or exposed, and then taking pictures and using social media to get the word out. And it's actually gone international over the past couple of years. We got work to do that. And then probably the most important thing that we've started doing is, and I mentioned earlier that we've got to get the word out to the public. We've started doing community outreach events where we do screenings for peripheral disease, neuropathy, even vision, blood sugar, blood pressure. So we've got a couple of those under, and it's one thing to screen people, but then you've got to get them to the right providers within a community so that they don't fall through the cracks. So that's really what we're all about. And anybody who wants to get involved, certainly please feel free to contact us either through our website or Dr. Melin.
All right. Thank you very much. And Dr. Bell, if you don't mind, the website again is?
It's www.thethesalsal.org, as in save a leg, save a life. So thesalsal.org.
All right. Easy enough to remember. Thank you very much. You've been listening to and watching the LymphCast show, episode 19. Before we let you go, let me go around the room and thank our panel individually. Our very newest member from New York, an RVT, used to work at Dr. Chuback's clinic, Jacqueline Sasek. Jacqueline, first of all, welcome. Glad you were here. Thank you for tonight. We'll see you next time.
Thank you. Thank you very much.
You bet. Dr. Mark Melin from Minnesota. Thank you, sir, for everything. As always, excellent input. And then if you could take a moment to thank Dr. Bell on behalf of all of us, we'd appreciate that.
Des, it was just a really distinct honor to have you with us all today. We all learned much, and we look forward to the work that and the servant leadership you're providing. Thank you.
Thank you. Thank you.
All right. From Arizona, Dr. Monika Gloviczki. Dr. Gloviczki, thank you very much.
Thank you. And I have to say that I enjoyed tremendously, and I hope that you will come back to us.
Well, thank you, Monika. I greatly appreciate that. I'd love to. It was really a pleasure. It was all mine.
All right. Very good. From California, Dr. Emily Iker. Dr. Iker, thank you for everything tonight. We'll see you next time, too.
Thank you. And thank you, Dr. Bell. And if you ever in Santa Monica, stop by and see the Lymphedema Center. From time to time, we do have lymphedema, lipedema, and venous insufficiency with ulcers. So we can learn much more from you.
Dr. Iker, I will make it a point because I do get out to California on occasion. So I would love to visit. So thank you for that.
All right. Thank you. And the creator of this LymphCast show, also the founder and owner of VitaSupport MD, makers of Vein Formula 1000, Lymphatic Formula 1000, physician surgeon from New Jersey, Dr. John A. Chuback. Dr. Chuback, thank you for everything, for creating the show, and obviously for all of your input on tonight's show.
Thank you, Paul. A couple of last comments. I want to make a nice announcement that we have added Dr. Emily Iker to the Clinical and Scientific Advisory Committee at VitaSupport MD, along with Dr. Gloviczki, who is our Chief Clinical and Scientific Advisor, and Dr. Melin. Dr. Melin, of course, bringing his expertise in wound care, and Dr. Iker, her expertise in lymphatic and lipedema. So congratulations and thank you very much, Dr. Iker, for joining us. And also, I would like to comment on the news that Dr. Iker shared with us about Dr. Hugo Parch. Dr. Parch was a legend and a giant, and I personally owe him a lot. And you talk about the importance of education, sharing ideas amongst colleagues. He certainly did that. And even the most fundamental things in terms of talking about the different stretch and bandages, short stretch and long stretch and medium stretch, that after years of surgical residency, I was completely ignorant of. And so sometimes little things, or what appear to be little things, can have massive impact in one's career and one's life and ability to care for patients. Just like tonight, we had some of those things. I love this idea of walk in water. Walk in water. You know, if listeners out there could remember one thing from today's show, I think, you know, Jacqueline has really put her finger on something. Walk in water. That's a great place to start. So thank you again, Dr. Bell, and thank you everybody on this wonderful panel. As always, I think I've learned a lot more than I shared.
All right. Well, thank you very much. Again, this has been a LymphCast, episode 19. We thank our panel. We thank you for listening and watching, and we'll see you next time for episode 20 of LymphCast.